So let's get started, shall we? So last week we discussed acute pancreatitis. I'm going to do a bit of recap later on with a bit of a quiz. And now I'm going to move on to a different case. So let's start on straight away. Okay. Right. So this week you meet a 65-year-old patient. They're attending the GP surgery as the family has noticed a slight yellow tinge to his sclera. That's your presenting complaint from the patient. You take a further history from this patient. And in further history, you find out that he's had a bit of a change in his bowel habits over the past 3 months. This has been accompanied by a little bit of weight loss and a bit of fatigue and tiring. What kind of things are we thinking in this patient already? Straight in B with pancreatic cancer, okay. Any other differentials? Any other differentials? Yeah, cholangiocarcinoma would be an interesting one, yeah. Hepatitis, yeah. Definitely on the list there. There's probably maybe a couple more I could think of. Don't have to have all the symptoms. Yeah, bowel cancer, liver mets, yeah. Liver failure, yeah. Any cause of liver failure, really. So there's a couple of differentials there for the patient. Yeah, hepatocellular carcinoma, yep, in the liver. So we've got a patient here who's got this painless jaundice, so we're a bit worried, aren't we, really, to begin with? There's been a lot of suggestion of a cancer in the chat already. And definitely in a painless jaundice picture, you're thinking of a patient who's likely to have some kind of cancer. It's a worrying picture already. Accompanied with the weight loss and fatigue, it's putting you heavily towards some kind of cancer. And then when we're thinking about bowel habit changes of the past 3 months, I think everybody in the chat and watching is thinking about something to do with the pancreas, to do with enzymes, that kind of thing. So let's move on slightly. So as any good medical student or doctor would do, we examine the patient, and while examining the abdomen, we find a palpable mass in the epigastric region, and it's smooth and non-tender. So this again is taking us towards, in the examination, we're thinking again, maybe some kind of cancer because it's painless. It's in the epigastric region, so it could be, could maybe be gastric stone. It could be in the pancreas. It could be in the gallbladder or the biliary system. It might even be on the edge of the liver. It's still palpable in the epigastric region. So we're still not 100% sure where it might be coming from. Okay. Right. But we mostly think in this patient it's going to be pancreatic cancer because we've just done acute pancreatitis, so that would be the best place to go in this next lecture slide, I think. So let's talk about the pancreas and its function anatomy and how this is going to associate with some symptoms the patient's going to get. So the functions at a basic level with the pancreas, we have the exocrine function of releasing bicarbonate and digestive enzymes. So what kind of symptom will this have if we stop in this function of the pancreas? Yeah, loose stools. What's the specific name you get for it when you lose the ability to release bile? How do we describe the stools? Yes, even with steatorrhea and cape. Well done. Yeah, so steatorrhea, the patient's going to get these smelly stools which rise to the top. The very characteristic of pancreatic cancer or any problem with the pancreas or biliary tract. So we have the endocrine function as well. So we have the alpha, beta, and delta cells, which consist of the Isle of Langerhans. Yeah, B straight in there with diabetes. What kind of symptoms are we going to get for the patient though? What patient might present with this loss of, yeah, polyuria, polydipsia, yeah. Okay, yeah. Weight loss, polyphagia, yeah. So mostly those kind of symptoms. So a patient with pancreatic cancer might present with these symptoms of diabetes rather than their loose stools or other symptoms you might typically get with pancreatic cancer. So these patients that come in with an acute onset, well, not acute, but maybe 3-month onset of diabetes might be due to pancreatic cancer. So you get this fatigue, weight loss, and increased thirst, as you said. And then the common bile duct. So we've already discussed that really. And you get this jaundice and Courvoisier's sign. Does anyone know what Courvoisier's sign is? I mean, you probably do. Yeah, it's a palpable gallbladder, but does anyone know what the physiology is behind it? So Courvoisier's sign is the way that you can, it's a sign that you can use to dictate or to tell you whether the jaundice is due to a stone or due to cancer. So as we talked about last week briefly, we will talk about it later on a bit more. If you have gallstones in the gallbladder, you get this thickening and tightening of the gallbladder. Therefore, it's not able to expand as much. Whereas if you have cancer, and then you get getting bile fluid building up, the gallbladder can expand because it hasn't had this roughing up of the inside of itself and tightening, so it can expand, and you get this expanded gallbladder, which is palpable. So Courvoisier's sign is if you have a palpable gallbladder, this is more likely the patient has pancreatic cancer or a cancer of the biliary tract. As we see here, and this is just a little diagram of the biliary system. So as you say, if you have a cancer down here in the pancreas, you're going to get a build-up in the gallbladder of a lot of fluid, which is palpable. Okay. So how do we pick up pancreatic cancer? It's very difficult to pick up in patients because it's often very asymptomatic for a long time. And we'll discuss why that is in a little bit. The most important thing is, as we said, painless jaundice. And you get a 2-week access appointment for patients if they're over 40 and have this painless jaundice. So any patient that comes to you, if you were in a GP surgery, primary care, or if you came to A&E and they were over 40 years old, had painless jaundice, and there wasn't any other obvious cause of why this jaundice was occurring, you have a 2-week access appointment for pancreatic cancer. And then alternatively, if you're over 60 and have weight loss, plus any of these symptoms, such as the diarrhea, back pain, abdominal pain, nausea, vomiting, new onset of diabetes, as we discussed, you get 2-week CT scan of the abdomen. So you can see that it's quite heavy-handed response to pancreatic cancer because it's so difficult to pick up. These are quite vague symptoms, diarrhea, back pain, etc. But if it's accompanied with weight loss, it might be quite unlikely it's pancreatic cancer, but it's very hard. If you miss it, it's very difficult to recover from that. So it's quite a heavy-handed response in terms of picking up these jaundice cases and weight loss cases for pancreatic cancer. So you've got to be very careful. And these questions that are quite likely to come up in exams, things like that. Because if you've picking up a patient, an exam question, and you're over 60 and weight loss plus any symptoms, you're going to have to give them a CT scan, even though it might not seem like it's quite not many issues there. You would have to still send them for CT scan. Okay. Right. So how do we investigate them? As we said, the first line really is CT abdomen, and this is pretty much definitive. If we can see they've got cancer or not. So So the CT abdomen will give us that picture, but it's sometimes very difficult with stage 1 or stage 2 because they're quite small cancers. And sometimes CT is not available. So alternatively, you can have ultrasound to try and pick up pancreatic cancer. But if a patient does have ultrasound, they still need to have a CT abdomen at some point. And then we have the CA19-9, which is sensitive for pancreatic cancer, which we take. And then we can take the ERCP, and this is used if the CT abdomen isn't definitive. The patient needs an ERCP so we can look inside the pancreas. And then a PET scan would let us know if there's any metastases, as we discussed in esophageal cancer a few weeks ago. And then LFTs as well for any metastases to the liver. So how do we stage pancreatic cancer? So stage 1 and 2, it's only from less than 2 centimeters and 2 to 4 centimeters. So it's very difficult to pick up these very small cancers which are hidden in the pancreas. So you might not even see them on CT scan. And then from T stages 3, greater than 4 centimeters, you can probably kind of see that on a CT scan quite well. And then 4, you've got invasion to other structures, and usually patients will have presented by then. And then again, with nodes, 1 to 3 nodes for 1, and then 4 nodes for 2. And then there's always 1 for presentation of metastases. And the staging is very similar to esophageal cancer. So we have stage 1 and stage 2, which are basically based on the T stages. So stage 1 and stage 2 is up to about T3. So if it's not any bigger than 4 centimeters, you're in the stage 1 or stage 2. And then stage 3 of pancreatic cancer, you've either got 4 and over nodes, or you've got a T stage 4, so you've got invasion into other structures. And then again with esophageal cancer, if you're in a stage 4, you've got metastases. So metastases really tells you that it's the worst stage of most cancers. So we'll have a little look on this, on the T&M staging for this image. You can see in stage 1, you can see how this small cancer can get lost in the pancreas, and there's going to be basically no effect on a patient really. And again in stage 2, unless you've got invasion into the main ducts, there's no way you can tell really that a patient's got this stage 2 cancer until you've got this stage 3 picture where you might still not even have any symptoms. Usually by stage 3 you will have maybe some invasion into the ducts at least, or some of these nodes might obstruct some of the ducts, and you might get symptoms for the patient. And then in stage 4 really you're definitely going to have symptoms because you've got invasion into either the duodenum itself, into the biliary tract, or even into the aorta, the vena cava. So this T&M staging just demonstrates really how difficult it is to pick up pancreatic cancer in these patients. So how do we treat these patients? Well, if you're lucky enough to be picked up at stage 1 or stage 2, for pancreatic cancer, you can surgically resect these cancers. It's quite a difficult surgery because surgery with the pancreas is always quite tough because it's quite like a fatty structure, so it's difficult to cut open and to stick back together again with when you're suturing. But it's usually quite a good outcome for surgical resection. And then depending on how the surgery goes, you can have chemotherapy. If you haven't got when you cut out, you either have a good margin or not so good margin, depending on if you think. So if you have a wide excision margin and you think that you've cut out most of the cancer, you'd say that's quite a good margin, and you don't need any chemotherapy. But if you think there might still be cancerous cells on the margin because it was difficult to cut it out cleanly, you'd maybe give the patient chemotherapy afterwards. And then all these patients have had resection of the pancreas. You need to replace the enzymes with pancreatin. But for stage 3 and stage 4 patients, it's a bit more difficult. So you can have surgery for these patients, but it's going to be no long-term benefit really. It's going to be palliative surgery. And then you're looking at endoscopic stenting, so using the ERCP to stent the biliary tract so that patients can have bile going to the duodenum, and there's no like buildup of bile in the gallbladder or in the liver. And for these patients, it's usually highly invasive, so it's going to be a chemotherapy regime with pain management and replacement of the pancreas enzymes again. And there's the regime at the bottom here, which is the Folfirinox regime, which is the most commonly used chemotherapy regime for patients with highly invasive cancer. But the outcomes for stage 3 and stage 4 for patients aren't very good. And you say here, 50 to 55% of patients who have got pancreatic cancer and diagnosed with stage 4, which shows you how difficult it is to pick up pancreatic cancer and how bad the outcomes are for those patients. Because even with stage 1 and stage 2 pancreatic cancer, I think it's 16 to 19 months is the median survival of these patients. So for stage 3 and stage 4 patients, it's not going to be very long, unfortunately. And a lot of it is palliative treatment and symptom support. Okay, so that was just the section on pancreatic cancer. Hope that was helpful. We're going to jump straight into another case, if that's all right. Okay. Right. So this is we've moved on for the epigastric region now, straight into right upper quadrant pain. So I think we probably all know where this is going to go, but let's play along. So we have a 40-year-old female now, and you're working in A&E. She's slightly overweight, and she's attended with pain in the upper right quadrant. She also noticed feverish symptoms, nausea and vomiting over the past 2 days. When you ask her, she's had no change in bowel habit, no other symptoms, but she's previously had medication history of dyspepsia. And you also notice with this patient, she has a slight yellow tinge, but she's had a bit of pain, so it's slightly different, and she's a bit younger. What are we thinking in this patient? So we're moving into the right upper quadrant pain. Okay, ascending cholangitis. Everybody always goes for the right answer first, which is good. I like to see that. So Stephen, Lily and Kate going for ascending cholangitis. Do we have any other differentials? Viral hepatitis? Yep. Okay. Yep, definitely. Okay. Primary biliary cirrhosis? Yeah. Good. So it's important when you're looking at a patient's history or when you've done a whole examination, history taking, to have a list of differentials really. Because it's, although on paper it's going to be maybe swaying you to one main differential, you need to have alternative ones, especially like for older patients, cancers, or for younger patients, diseases which might be quite deadly, because you want to exclude these. So you need to make sure that you've got rid of those. So you need to have them on your list to exclude. Malaria, yeah, interesting. We could definitely, if she had a history of travel, definitely be one to exclude. Cholangiocarcinoma, yeah, she's maybe a little bit young, but it's, if we can do the ultrasound, we might as well check for it. So most of these differentials are going to be towards the biliary system, I think, really. So we've had most people put in originally ascending cholangitis, but we should also have cholecystitis in there as well. We should have also have any other biliary stone disease as well. And what's the importance of the slight yellow? What's the triad we have for ascending cholangitis? Charcot's triad, yeah, great. Does anyone know what the other two symptoms are for the pentad? There's a pentad he has as well. Yeah, nice. A with hypotension and confusion, yeah. So you have shock. If the patient's got in shock and has confusion, this is called it's the pentad, which is the 5 symptoms. So it's the Charcot's triad plus hypotension and confusion. That's not very useful, but it's interesting, I guess, if you're interested in that. Okay. But Charcot's triad, what's Charcot's triad we have? What are the symptoms? What are the... Yeah, so right up quadrant pain, fever, and jaundice, a Charcot's triad, and this points us towards ascending cholangitis. Great. Okay, so let's examine this patient. So what's the first thing that we're probably going to see in this patient? We're looking from the end of the bed. It's been in the history, but what's the first thing we're going to see in this patient? Yeah, Stephen, with jaundice. Great. So the first thing we're going to see from the end of the bed is the patient's going to have jaundice. What other things might we see in this patient, do we think? What are the stereotypical things we might see in a patient with ascending cholangitis or Henry biliary disease? Yep, maybe slightly overweight. Yeah, the patient might, when you're attending, have a slight fever, be visible. Yeah, so we've had a few things in the chat about the F, so female, 40, fertile, fair. Might be tacky, yeah. Itching because of jaundice, in pain, yeah. Okay. Let's go through the abdo examination. What things we be looking for normally in abdominal examination. So we're going to be checking for the bruising in case there's a pancreatic picture. Distended abdomen, do we think there's been a perforation anywhere? Is there a pulsatile mass? Could it be from a AAA? We're going to palpate for Murphy's sign. So we'll talk about Murphy's sign in a moment. Is there any signs of peritonitis? So do we have rebound tenderness? Is the abdomen distended as well? So Murphy's sign is what we look for in acute cholecystitis. So we would check for it in this patient as well, just in case we've got accompanying cholecystitis as well as ascending cholangitis, or if the picture is actually acute cholecystitis and not ascending cholangitis. So you probably don't. We ask the patient to exhale, so we get them to breathe out. Then you place your hands below the costal margin, so just under where the liver would be. And then you ask the patient to inspire, so it pushes the liver down alongside the gallbladder. And if the patient's hands palpate the gallbladder, the patient will stop breathing and wince, and it'll be very painful for them. Okay. And that will show you acute cholecystitis, so inflammation of the gallbladder. Okay, investigations. Let's have a look. Ooh. So what kind of investigations are we going to do for this patient? So they're coming in with a fever, temperature, they've been vomiting, they've got this right up quadrant pain. FBC, yeah, very important. FBCs, RFTs, UNEs, yep, classics. Observations, yep, very important. Vitals are always very important. CRP. Anything specific for the gallbladder we might do? Yeah, ultrasound, very important. Bilirubin, yeah, great. So we want bilirubin levels so we can tell whether this jaundice is caused by a prehepatic picture, posthepatic picture. Excellent. All right, let's go through them. Let's see what you think from these. So we've done the FBC initially. So red blood cells are normal. You see the white cell count slightly raised. Oh, yeah, beta blood culture urinalysis. Okay, great. So what would be the reason for blood culture, do we think? So B is very right saying blood culture analysis, because a lot of patients with this ascending cholangitis picture can also have accompanying sepsis. So it's very important to make sure that this ascending cholangitis hasn't spread to the rest of the body. So we need to make sure we're taking bloods for potential sepsis and doing those monitoring as well. From this FBC, we can see that the patient has got an infected picture, really, so that we can raise white cell count and neutrophils. CRP is also significantly raised, so this accompanies our inflammatory response picture. So we've done a serum amylase just to make sure there's no pancreatic involvement. I said before that LFTs were done, so we've got a raised ALP, raised GGT, and a normal ALT. So what picture do we get from this liver function test? Yeah, so it's an obstructive picture, so it's likely to be in the biliary tree. Or a post-liver picture. Great. And then again, we can do the bilirubin. So we've got a total raised bilirubin, the conjugated is raised, and then conjugated is normal. So the conjugated is raised. The bilirubin's been for the liver already, so the liver's fine. The issue is after the liver. So it goes with our picture again with ascending cholangitis. And there's an obstruction in the biliary tree. Okay. And then ultrasound, the most important investigation really with any biliary tree disease. As I said before, that we need to all investigations to check for sepsis. It's very unlikely for patients to attend with ascending cholangitis only and not have any bacterial infection anywhere else in the body, really. And it's very likely for patients who have ascending cholangitis to go on to develop sepsis. So we need to take these bloods to make sure. Okay, so in ascending cholangitis, the most important part is to admit the patient, really. So once the patient's admitted, then we can start doing proper treatment for the patient. But it's fundamental to admit patients with ascending cholangitis. Okay, so how do we manage ascending cholangitis? So it's actually got quite a high mortality rate, ascending cholangitis, so it's really important to start management very quickly. So we start off with quite broad antibiotics with IV piperacillin, tazobactam. And then we need to move on to fluid management as well with the patient. So we're taking the vitals of this patient and respond to that with fluid management. A lot of the time, patients can attend with low blood pressure as well as ascending cholangitis, because you can often get a lot of end organ failure. And then again, other things that we'd assess from A to E, we have give the patient oxygen if required. And analgesia in patients with ascending cholangitis is usually diclofenac, because we want to make sure it's reducing the inflammatory effect. And then as the patient's been vomiting quite a lot, it's important to take the UNEs and to replace electrolytes as well. So the main treatment for ascending cholangitis really is the ERCP, because we're going to have a picture really, we're going to have a stricture of the biliary tract, or we're going to have a stone blocking the biliary tract, something in the common bile duct, which is stopping bile from moving down to duodenum. So the main treatment is going to be ERCP for biliary decompression. And it actually depends on the clinical picture. If the patient is in ICU and very ill, we're going to wait for the patient to stabilize first and then take them to ERCP. But if they're quite, well, relatively stable, the ERCP can be done quite soon. But the patient isn't going to get better until this decompression is done. So we have to do it, but we have to make sure the patient is stable first. Okay. Right. Yeah, so as we said, most of the cases involve biliary obstruction. So you can have it from patients who've had previous surgery, could be from previous pancreatitis. Patients could have presented with previous radiotherapy or chemotherapy, which is called biliary strictures post that. The most common cause are stones, though, and these are easily removed by ERCP. And the strictures previously mentioned can be just stented, and that's it. You just stent the strictures, and that's the patient's fine after that, once the bile is flowing out. But we need to have the ELCP to check what the cause is first, and then we can treat it. So with the ascending cholangitis picture, we took a history from the patient, we did the examination, we did our blood investigations, which showed we had this inflammatory response, and it was most likely to be a post-hepatic picture of why the bile was building up and why the red blood cells, why the bilirubin was being deposited in the skin. And then after that, we took an ultrasound which showed us that we had dilation of the biliary tract. And then we thought we need to find out why we have dilation in the biliary tract, and performed an LCP and then treated it that way. So it's quite a simple way to go through it. I think hopefully that's quite helpful. Okay, so now we get a different patient, and we discussed a little bit earlier about some of these symptoms, some of this pathophysiology. So we had this patient. Say you're a medical student, and you were in the ultrasound room, and the ultrasonographer asks you, "What do you think this patient has got? What do you think they might have got from this picture, this labeled picture?" Say they were also, before they attended the ultrasonographer, they also had a fever as well, felt quite ill. Yeah, so B say acute cholecystitis. What makes you think the patient has acute cholecystitis? So we've got this picture, we've got stones in the bile duct, we've got a thick wall, and the patient's got a fever, which makes us think that, and we've also got free fluid here. So altogether, this goes for acute cholecystitis. So on this, explain the ultrasound. So the presence of stones causes the wall to be thick and sclerotic. We talked about this slightly at the start of the lecture. And then this free fluid is likely to be pus. And you can see that the gallbladder is also full, quite thick, so it's likely to be pus inside the gallbladder as well. And accompanied with a fever would go towards a picture of acute cholecystitis. Okay. Accompanying the quiz from week number 1, what city is this? Oh, not Hong Kong this time, although we're still in Asia, not Seattle. And it's not Paris either with the Eiffel Tower. Yeah, Tokyo, nice. Well, okay. So this is Tokyo. So acute cholecystitis has a grading system based. It's called the Tokyo grading system. And the severity basically depends on whether the patient has end organ dysfunction or not. So alongside ascending cholangitis, acute cholecystitis also has quite high morbidity. I think it's 10% of patients, 10% mortality in some high-risk situations. But the Tokyo grading system is from grade 1 to 3, and stage 3 is where you have organ dysfunction, and patients who have organ dysfunction need to be admitted to the intensive care unit. It's not that useful, it just tells you that and lung dysfunction, you need to send them to ICU. Okay. How do we treat acute cholecystitis? So as before, we need to make sure we manage the pain of patients. So paracetamol, diclofenac. We have diclofenac again to make sure it's usually more diclofenac than paracetamol because we want to reduce the inflammation. Again, we want to make sure patients have been given fluids. And in acute cholecystitis, it's been shown that actually crystalloids like Hartmann's have actually got a benefit over just giving normal saline to patients. And antibiotics, it's quite difficult for antibiotics in acute cholecystitis because it's different in different regions. So normally you would just ask, you would take a culture from a patient if they had a septic picture, and if there was a culture growing back, you would aim it towards that. But it's very difficult to get because you can't just drain it just to take a culture from the gallbladder. So you're most likely to go for an E. coli, an antibiotic that aims at E. coli, because E. coli is the most common cause of mild acute cholecystitis. So you need to make sure that the antibiotics you choose have good gram-negative coverage and have good gallbladder penetration. It's usually ampicillin, which is a good example for what you can give to patients with acute cholecystitis. And then, well, the most important treatment of acute cholecystitis and definitive treatment is early surgery. Okay. So Nye said we should give patients surgery within, meant to say 7 days, not 7 weeks. Yeah, so we should give surgery within a week or 7 days, but really the ideal is within 72 hours. So patients who have acute cholecystitis, we should give treatment to them surgically within 72 hours. And this is in the form of laparoscopic cholecystectomy. And if patients are not able to have surgery, so they might have comorbidities, or they might have Tokyo score of 3, so they're in ICU, we can give patients percutaneous cholecystotomy. And this is where we just pass a catheter in through the liver into the gallbladder, and it drains away a lot of the pus from inside the gallbladder. And the aim of this is, so we want an aim for most of our treatments. The aim of the cholecystotomy is it can either relieve the patient's symptoms completely or enough so that they can go to surgery. But in patients that are never going to be surgical candidates, maybe like 90-year-olds with comorbidities who would never go to surgery on one of their better days, percutaneous cholecystotomy is very helpful to remove their symptoms and would still be what we give them. Okay. Has anybody got any questions? And I'm going through quite quickly. Okay, carry on. Right. So this is quite a helpful diagram from, it's the AUGIS, which is the gastro society in the UK. And this is the acute gallstone pathway. So anything that's gallstone based, this is basically how you would differentiate between what the patient has, basically. So you can see in the middle you have this typical biliary pain, so right up quadrant pain, straight to the ultrasound, and this confirms gallstones. Then it tells you what to check afterwards. So that, as we said, FBCs, LFTs, and lipase. And this can distinguish whether it's going to be cholecystitis, a jaundice picture, just normal symptomatic gallstone disease, or acute pancreatitis. And all the treatments, and there's a few pathways and treatments on there. So the link's down here. So as I was saying, my lecture 1 and 2 got uploaded onto the Pancreatic slideshow Dropbox, and these will be on there as well afterwards. So this is a good link, the AUGIS, or if you want any quick ways to find out how to treat biliary diseases or to pick them up. Okay. Right. So what about just symptomatic gallstone disease? So patients don't always have accompanying fevers with these gallstone diseases. As in the exemplar history, as we all know, 46-year-old female, pain in the right upper quadrant, um, comes after eating, usually lasts about 2 hours. The patient's had previous episodes, but no other symptoms. The vitals are normal. They've got a little bit of tenderness in the upper right quadrant. Do we treat these patients? What do we do with these patients?
You've got two Francescas, haven't you? Please.
Oh, make sure you make sure you mute the microphones.
No.
Elective cholecystectomy? Yeah. So A said, do we do an elective cholecystectomy? Yeah, we do. We do that on some patients. Yeah. Kate saying, would you do an ultrasound to make sure? Maybe diet advice. So you would definitely do an ultrasound to make sure. Yeah. We're not just going to jump in with the cholecystectomy. Definitely to make sure that it's definitely gallstone problem. So we do definitely do an ultrasound to make sure. So in these last two sections about symptomatic gallstone, it's all about where the stone is really. So let's jump into that next bit. So yes, we do treat. We definitely treat because we give analgesics in the emergency setting. So these patients are in pain, so we give them analgesics to begin with. And this is really important, a fundamental for most parts of treatment. And then we treat dictated by what ultrasound says. So these patients have an ultrasound and we do LFTs. So what we want to know is, we want to know where the gallstone is. So we've got pain in the right upper quadrant. Is the gallstone in the gallbladder? Is the gallstone in the biliary tract? And then, so this, we can either see this on ultrasound by either having stones in the gallbladder, or we have a dilation of the biliary tract, which will show the stones are in the biliary tract. And then we can do the LFTs, which might say if they're abnormal, the abnormal LFTs will tell us that there's stones in the biliary tract. Okay. If we do ultrasound, it's usually looking for dilation of the biliary tree, but if we can't see it and we're unclear, we might be able to do an MRCP, which the MRCP is just like an MRI scan, but of the biliary system. So it's a very high definition visualization of the biliary tree. And that'll tell us whether there's dilation or stones present in the biliary tree. But it's normally we just do ultrasound and LFTs. Okay. So if the patient's got symptoms, so they've got pain in the right upper quadrant, and we do the ultrasound and it shows us that the gallstone is in the gallbladder, we do an elective laparoscopic cholecystectomy. So within 6 weeks, hopefully, so you give the patient analgesia and then book them an appointment for 6 weeks for laparoscopic cholecystectomy. And then we do ERCP. There we go. Great. So if the stone is in the common bile duct, then we're going to perform an ERCP with laparoscopic cholecystectomy within 72 hours. So if it's in the common bile duct, we need to keep them in hospital. We need to do an ERCP to take out the stone, because it's quite likely the patient might develop further complications like ascending cholangitis or pancreatic acute pancreatitis if the stone has migrated its way into the common bile duct. And as you can probably appreciate, if you do a laparoscopic cholecystectomy, it's not going to affect this stone that's already in the common bile duct. So we have to do something about the common bile ducts, and that'll be the ERCP. So if it's in the gallbladder, elective laparoscopic cholecystectomy. If it's in the common bile duct, we need to do an ERCP to take it out. Okay, but we definitely treat in both cases. So we definitely treat because patients that present with symptomatic gallstone problems will 100% return with more issues. So that's why we take out the gallbladder. All patients that present with symptomatic gallbladder problems will present again. Okay. But what if patients are asymptomatic? Do we treat those? Ooh. Kate says no straight away. Very active. Oh, we've got a question as well. Okay, can you measure the width for the common bile duct? Yeah, you can measure the width with the common bile duct with ultrasound, but it's not as accurate with the MRCP. So if you want to measure the common bile duct width accurately, you want to do an MRCP. But in most cases, you can tell whether it's dilated or not dilated, and that's the qualitative answer is usually enough to tell you if you should go for an MRCP. Or if it's very, well, you can get, it's qualitatively yes or no dilated, but it can be very dilated and then you're going to go straight to the LCP. Okay. B says, depends where it is maybe. Yeah, that's a good observation because we've got another diagram ready for the stone to move. Okay, so in asymptomatic gallstone disease, if it's in the gallbladder, leave it, let it be. Yeah, there we go. So you might pick this up if you're doing maybe the patient's got a fatty liver disease and you're doing an ultrasound and you might pick up that they've got a gallstone as well. Because it's very likely for patients who've got fatty liver disease or cholesterol problems to also have gallstones. But there's no need to treat these patients. It's very unlikely for them to have a flare-up or any issues with their gallstones. But as we've seen before, if it's in the common bile duct, we should treat these patients. So we should do the same thing. We should perform an ERCP on these patients. Because these stones eventually are going to cause a problem. If it's in the common bile duct, it shouldn't be there, and it's going to be usually the width of the common bile duct and it's going to cause an obstruction at some point. So either in the pancreas or maybe in the duodenum up here, it might cause an obstruction, and that's going to cause issues for the patient. So if the patient's asymptomatic, but it's in the common bile duct, we should do an ERCP, take it out, and then afterwards we'll do a cholecystectomy as well. So quick review. If it's in the gallbladder, patient's asymptomatic, you pick it up when it's in the gallbladder, let it be. If it's in the common bile duct, you should do an ARCP, cholecystectomy. Okay, right. Let's move on to the quiz, shall we? New share. Hold it. Oh, right. Okay. Can we all see this? Yes, no? Can we see the quiz? Yeah, great, thanks. So this quiz is going to have questions from all lectures 1 to 4. So let's give it a go. So we got 28 people. Yeah, 28 people in the chat. So I'll wait for about maybe 20 plus. Okay. 5 more seconds. Oh, somebody left. Okay, ready? Let's get in. Oh, okay. So, oh no. Oh. Okay, so we have a lot of people going for hemorrhagic shock and stage 1 being a decrease in BP, but actually it's stage 3. So in hemorrhagic shock, you don't really get a change in BP until stage 3. So it's stage from 1 to 4, as I said in lecture 1. In stage 1 and 2, it's only up to 500 and then 1,000 milliliters of blood loss. And you don't really get a change in BP in these patients. It's quite good compensation from the patients. So you can see that if you're in hemorrhagic shock stage 3, you have to be in stage 3 until there's a decrease in BP. Then you can see that patients with decreased BP really do need some medical treatment. So it's not until stage 3 that you get a decrease in BP in hemorrhagic shock. Okay. Okay, great. So again, from one of the other lectures, for patients with first-line bleeding peptic ulcers, it's usually, we call it dual therapy. So we either have clipping with adrenaline, or we have sclerotherapy with adrenaline, or some kind of cauterization with adrenaline. We normally use dual therapy. So one method to clip it or to close the occlusion, and then adrenaline to stop the blood vessel supplying blood to that part where it's bleeding. Okay. Okay. Don't worry, there's 10 questions this time, so there's plenty of time to get on top of the scoreboard. Okay, yeah, most people are going for banding there. Yeah, so the first line therapy in esophageal varices bleeding is banding. That's the first line. And then after that, we can give patients a TIPS procedure if necessary. But then also in patients who have esophageal variceal bleeding that can't be treated by banding and the hemorrhage is too large, we can give them a Sengstaken Blakemore tube to occlude the bleeding, but only in heavy bleeding, which is uncontrollable. Okay. Got a shift. That's a tricky one. Oh, great, nice. So in Barrett's esophagus, as most people got that time, it's squamous cell metaplasia to columnar cell metaplasia to columnar cells. Great. Any questions left? Okay, great, yeah. So all these are red flag symptoms for esophageal carcinoma other than cough. So donophagia is painful swallowing, dysphagia, difficulty swallowing, and then hoarseness of voice is from this obstruction from the vagal nerve. Okay. This is one from last week. Okay, tricky question actually. So the pancreas scoring system, we're normally looking for low calcium. So it's one of the things I was trying to get across last week is that hypercalcemia, so a high calcium can be a cause of pancreatitis. But the pancreas scoring system is for severity, so how severe is the pancreatitis. One of the dictators of how severe it is how low your calcium is afterwards. So after you get pancreatitis, you get hypocalcemia, so low calcium. And usually it's less than 2 millimoles in the pancreas scoring system. If you're less than 2 millimoles of calcium, that's a point on the pancreas scoring system. So hypocalcemia is for severity of pancreatitis. A few people go with potassium and lactate. It's not on the pancreas, it's not on the scoring system, but lactate might be something you might be looking at if you looking for an abscess afterwards. But it's glucose. So as we mentioned slightly in this lecture, one of the pancreatic functions is regulation of sugars. And in pancreatitis, you'll get maybe in some patients necrosis due to lack of blood supply to the islet Langerhans. You might get a high glucose. So that's one of the parts of the pancreas scoring system is a glucose of greater than 10 millimoles. Okay. Great, most people got that all right. Excellent. So one of the most common causes of medication-induced pancreatitis is azathioprine. Great. This is a question last week, might be a tricky one. Okay, great, most people got that one right. So we're looking at the acute management really, this patient. So in the acute scenario for this patient, you want to get rid of the gallstone. So you want to take the gallstone out of the bile duct. So we're going to do that with the RCP and sphincterotomy. Later on, we would do a laparoscopic cholecystectomy, as we said just a minute ago, but the most acute management is the RCP. finishing the lecture, so hopefully some people might get it right. Great, yeah. So I kind of tried to trick you this one because I put 60-year-old patient rather than 40-year-old patient, but if they're over 40, then it also applies. So painless jaundice is the one we get a 2-week access appointment. So for the new onset diabetes and back pain, you also need weight loss, and that was for a CT scan. But for a 2-week access appointment, it's painless jaundice. Okay. Last question. Hopefully everyone gets this one quickly. Yeah, so from the lecture, just something you have to learn. CA19-9 is the most sensitive pancreatic cancer. So let's see what the scores are. Great, well done, sir. Okay, so that's it really. I'm not going to do my lecture for a few weeks because I have exams, but thanks for coming. Let me pop this another feedback thing in the... Oh. So there's not another feedback thing on here, but I'll get Fraser to put a feedback form on the website. If anyone wants to look at the PowerPoints, they're on the Pancreatic group, bank, things like that. If you have any questions, I'll stick around for a few minutes as well, if you want to put anything in the chat and I'll answer some questions. But if you want to go, feel free to go. Right.